In the bright, overconfident theater of modern surgery, anesthesia likes to arrive dressed as a miracle. Smooth induction, silent muscles, and the comforting illusion that biology has agreed to behave. Then, malignant hyperthermia barges in like an uninvited critic, turning a routine case into a medical panic with the dramatic timing of a collapsing chandelier. Malignant hyperthermia is a rare life-threatening reaction triggered in susceptible patients by certain anesthetic agents, especially some volatile inhaled anesthetics and succinylcholine. The problem is not that the drugs are evil, it is that the patient's skeletal muscle cells are carrying a genetically temperamental calcium channel that throws a tantrum when provoked. The result is uncontrolled calcium release, relentless muscle contraction, rapid oxygen consumption, carbon dioxide production, acidosis, and a body temperature that rises as if the patient has become a very expensive kettle. Early warning signs matter more than heroic speeches. During anesthesia, the first clue is often a sudden rise in end-tidal carbon dioxide that refuses to obey ventilation adjustments. Soon come tachycardia, muscle rigidity, rising body temperature, metabolic and respiratory acidosis, and sometimes dark urine from rhabdomyolysis. In other words, the body sends an emergency memo written in all caps. The response must be swift, organized, and refreshingly boring if done well. Stop triggering agents immediately. Call for help. Hyperventilate with 100% oxygen. Administer dantrolene without delay, because this is the one time where muscle relaxation is not optional decor but a moral imperative. Active cooling, treatment of acidosis and electrolyte disturbances, management of arrhythmias, and monitoring for complications should follow. The anesthesia machine should be flushed and prepared for a non-triggering anesthetic, because the room itself should not remain emotionally attached to the original mistake. Preparation is the real plot twist. Teams that rehearse malignant hyperthermia drills, stock adequate dantrolene, and know their protocol are much less likely to turn a scare into a tragedy. A thorough preoperative history, including prior anesthetic events and family history, can identify patients at risk. If susceptibility is suspected, non-triggering techniques and careful planning can keep the case calm, efficient, and far less cinematic. For a video, the message should be clear. Malignant hyperthermia is rare, but in anesthesia it is always urgent. Recognize it early, treat it decisively, and prepare before the first incision. In the operating room, that is as close as medicine gets to a happy ending.